Hello, welcome to Progenesis webinar session number 11. I am very pleased to have a great panel of experts today. I have with me Dr. Heather Huddleston. She is a professor, an OBGYN from the University of California, San Francisco. I have with me Dr. Cohen, and he is the co-medical director for IHR, Institute of Human Reproduction. I have with me Dr. Koo. He's the medical director of IVF Dallas. And we have with us Dawn Davenport. She is the executive director for Creating a Family, an organization that is dedicated to supporting patients through infertility, but also covers a lot of aspects, fostering and other patient supports. And we are very pleased to have Claire, and she is a current patient undergoing fertility treatments. She'll be giving us her perspective as a patient. Thank you so much to everyone. And let me first start my first question, and that is, what challenges are you guys facing today with COVID-19? And I'll start with Dr. Huddleston, and then the same sequence as before.
Well, the biggest challenges I think happened in March and April when we had to shut down the clinic for all of our patients. And, I think that was extremely difficult for people that had been waiting months to, get started with their fertility treatment. So that I think was really hard. I think now we have a different type of challenge, which is just re-engineering and reorienting the clinic around a more socially distanced way of practicing. So, there's a wide range of things that we're doing. We're also required, and I don't know if the other physicians are in a similar situation, but because we're part of a university healthcare system, we are required to test our patients a couple of times prior to their proceeding with the treatment. So there's a wide range of sort of new procedures and things that are in place for us to be able to deliver the same kind of care. But I'm excited to hear what Dr. Koo and Dr. Cohen also are doing and learn from them.
Very good. Dr. Cohen?
Well, first, let me just say thank you very much for inviting me. It's a pleasure to speak to you and my colleagues here and all of the patients out there. No question. I echo what Dr. Huddleston said 100%. It was very difficult for patients to stop suddenly, whether they were waiting or whether they were in something and we had to cancel them. This is really painful, but we did. And I have to say, I'm extremely proud of our patients as well as our staff for managing this. Pretty much everybody stepped up and they said, yes, I understand this is a difficult problem and we have to deal with it. We very quickly instituted some very fundamental rules and regulations that we adopted from, CDC, from ASRM, of course, et cetera. And they fundamentally revolved around social distancing, masks. This is when we started to get up again, limiting the number of people that could come into the clinic for surgical things, for testing everybody to be sure that they were negative before they got anesthesia, for things like hysteroscopies. And it's worked out really well. I think we learned a lot. I think we've, on the fly, figured out how to decrease the number of people that we need in the clinic at every different level, whether it's at the front desk or the doctors, the nurses, et cetera, ultrasound personnel. And we've also figured out that we can do a lot from home. We have the technology and we're using it. So I too am interested to hear what's going on in Texas. And so I'll pass to Dr. Koo.
Yeah, no, thank you also for having me here. But I agree with my distinguished colleagues. They definitely hit it right on the tip of the nail there, that basically it was so tough to close the office. We closed for roughly 2 months. I was just heartbroken for the patients where we had to delay their care. And you're right, now it's just a new way of working, a new way of living. And we've been doing a lot of telehealth, telemedicine. where the patients really have really gotten really good at Zooming, I guess I call it. We use the Zoom app. And but I think one of the difficult things lately, and we just talked about, is that sometimes the spouses aren't able to make it because of the COVID-19. And so sometimes it's hard, let's say during a transfer, that they may not be present. That may be hard for the spouses. At our facility, we have decided just recently to allow spouses, but I think every location has their own specific protocols that they should follow, and that makes good sense. But I gotta give a shout out to all the patients, because they have really truly adapted super well. I was really worried that with all of these restrictions and all these extra tests that we'll have to do for testing for COVID, that the patients would be upset. But I gotta tell you, every single one has said, like, you know what, no problem. This is what we gotta do. This is what we gotta do. So I've been very proud of the patients, and so yeah. It's been an interesting ride, and looking forward to seeing how this all plays out.
Fantastic. Don?
Well, I'm echoing much of what other people have said. I was going to say, I mean, certainly people were devastated. And it seemed to be kind of equal, people who were just beginning or people who were in the midst when things shut down. I anticipated in a way to start hearing people say, oh gosh, I'm worried about getting back in. Is it going to be safe? I'm not hearing that at all. I think people are kind of like, yeah, this is worth it. I'm willing to jump through the hoops. Let's just get started. So that's echoing what the other doctors have said. I do think, and this is something you're going to be talking about in a minute, we are hearing questions about, so if I do get pregnant, what does that mean? A few people are questioning, is this a wise thing? Should I be trying to get pregnant? We aren't seeing that. The questioning as much about going forward. People are still wanting to go forward because we preach so much that time is not on your side. If they happen to be younger, they might consider that. Otherwise, they really aren't. But there is an underlying worry. We recently, we will be soon releasing Creating a Family radio show podcast with Dr. David Adamson, talking about risks of pregnancy and risks of pregnancy and to the future child if the mom were to get COVID during COVID-19 during her pregnancy. So we are seeing some of that, and I think we will see some more, I anticipate.
Very good. Thank you so much. Claire, what is your perspective as a patient? What kind of challenges have you seen?
Yeah, so I mean, echoing what everyone said, there's a lot more procedures at my clinic, but I don't view them as an inconvenience. I'm very appreciative of them. I think that they're, the measures that need to be put in place to keep people safe during this time. So I don't mind it at all. And, when we were starting back up with everything after the clinic being closed for about 2 months, we were, considering like, what are the risks and, is it worth it to us? And for my husband and I, the decision was like, we definitely want to move forward. We don't want to wait. We think it's worth whatever the risk is.
Thank you so much. We have received a number of comments in the last webinar and prior to this one from patients who were saying they didn't get enough orientation and information about COVID-19. How do you guys handle that communication and the emotional supports for patients that are, completely unaware of the impact that could happen if they take that kind of, treatments? What is your communication with patient was like? And I'll start with you, Dr. Hedelson.
Well, I mean, I think it's interesting feedback to hear from the patients that you've had on your webinars, and I guess I'd be curious to also hear from our patients about that. It's something that we would strive to do well. We've definitely had a lot of communication with our patients through sort of messages, broad messages that are going out to kind of everyone in cycle, sort of updating them on what we're doing in the clinic and what's going on with cycles. And then we've been trying to keep our website updated with a lot of the just guidance, recommendations, things that CDC says, things that ASRM say. It's an interesting point. And I think it makes sense that patients, need that information and want that information.
Thank you so much. Dr. Costa?
Similar. We're similar. I think we've really exploited our electronic communication with patients through email, we have a portal system, through our website, and of course the telephone. We tried to take a global approach, not just the medical questions and not just those fears, but as well to how do you manage this, emotionally? Should we link people and try to be proactive as a liaison between us and help that people might need emotionally? And so we're not experts in that field, but we have access to these patients, so we can speak to the experts and engage them and allow them to, meet with our patients, whether it's electronically also or, email, phone, etc. And when things are very serious, of course, we've been talking to them very personally on the phone. We've had some people who were positive. That creates a whole nother set of concerns and fears, and that has to be managed very delicately, emotionally, sensitively. I think that's pretty much how we've managed it. We've also really tried to be proactive in predicting what's going to happen to people and putting that in the form of a blog or on our website, so people can read about it. Not long treatises, but just short things to tell people, what to expect in this whole process. Do I have to wear a mask? Will somebody take my temperature? What's going to happen when I show up? Where do I park my car? It's amazing how little things become very big when you can't figure out how to, enter the buttons to get into the clinic if somebody hasn't told you, because you're worried about touching stuff. So I think we've really tried to think through the nuances.
Yeah, I agree. I think that the patients really get bombarded a lot daily just from regular news sources about COVID, but not a lot of it is about reproduction and COVID. And so we try to put on our webpage, just right on the very top, here are some resources and it links to some trusted sources like ACOG, ASRM, about reproduction and COVID and pregnancy and COVID-19. So we hope that helps, but I think that our office could do a little bit better to try to push out more information. We are utilizing social media a lot. So we're blasting it on our Facebook pages and our Instagram pages, like, what happens if you get pregnant with COVID? And then we write a little thing. So I'm hoping that we're getting the message out, and then hopefully that voice is just so loud from a collective, a lot of the infertility practices, that hopefully the patients are getting that information. But I also agree with Dr. Cohen that the nitty gritty of telling the patient exactly, like, okay, when you arrive to our front door, you got to call, and then we will greet you at the door. We'll take your temperature. And you're right, these little tiny steps patients really need to know. And our front offices are telling those patients when they make the appointments. But I think we could do a little bit better. But we're definitely trying to push to social media to help spread the word about what we think about COVID-19 and reproduction.
Thank you so much. Don, what do you hear from patients? What's the most concerning, concerns that they have?
Their concerns are now that they're different. 2 months ago, when things were shutting down, their concerns were, what is this going to do to my cycle, or more importantly, what is 2 additional months? I've already waited this long, and you're telling me that time is not on my side. You're telling me that I need to, that my clock is ticking loudly. So that was a frustration. Now that things are starting back up, there's a great deal of relief, quite frankly. And as I mentioned before, the procedures, they may seem onerous to the doctors here on this panel, but truly that's not what we're hearing from patients. And I think the patient that we just spoke with said the same thing. We are hearing, though, if somebody is getting pregnant, and we haven't had a lot of people because most of them are just getting back into treatment. But when they do get pregnant, we are hearing people say in advance, well, is this a smart thing? Am I doing, they're willing to do it because they're not willing to wait. But there is that underlying niggling concern that says, what happens if I were to get COVID? Which is why, and let me just mention to both to the audience as well as to the doctors, our podcast is free for anyone. You can, any of the doctors who might be listening, just contact us. We will send you a link and you can directly embed the audio player that will play or we could send you a link to the recording, the audio recording. And we spent an hour talking, again, with Dr. David Adamson, former president of ASRM, and I think, not sure where else, but anyway, I had to read his bio again.
Yeah.
But anyway, so that I do think that's going to become the next issue, because women who are pregnant now are worried. In fact, there's an ongoing study out of UC San Francisco that's looking, so let me just put a plug into that, looking for participants who they need to be less than 12 weeks pregnant. I don't know if I think they're still accepting applicants. So anyway, throwing that out there.
Yeah, so Dr. Huddleston is part of the study. She is an investigator in that study. And
oh, excellent.
And
throwing out a plug for you. We plugged it hard on our show too. We've been sending out through our media. And I had 2 people come back and say, oh, one was 14 weeks and one was 13 weeks. And they said, can we get in? And I went, well, you'll have to ask them. I don't think so, but I don't know if they even followed up, because anyway, I thought that was funny. I'm 14 weeks. Will they take me? Everybody wants to participate that we've talked to.
Yeah.
Exactly.
Well, we're plugging you as hard as we can.
Thank you.
Yeah. Claire, in your experience, did you satisfy all your questions with your current provider? Do you have any suggestion of how this could be improved, or the communication has been well so far?
Yeah, the communication went well with my clinic. They sent out a lot of email blasts. I did a telehealth appointment with my doctor when they were getting ready to start up again, and she was able to tell me that I was able to start. So that was a great meeting, and she was able to answer a lot of my questions. I also follow my doctor on Instagram, and she posts good things, kind of showing some of the precautions that they're taking around the clinic and whatnot. So that's been helpful.
Very good. To follow up on this same question for the rest of the panel, what do you guys think about the communication? Obviously, the communication is not going to be just the clinic. You know, this is a major pandemic, and the information is not ready to your guys in the first day. You have to look at the studies. You have to look at the information coming from CDC and ESHRA and SRM. Have this organization provided you with enough information?
Are we going in order here?
Yes. You can start, Dr. Cohen, and then I will switch to Dr. Huddleston.
I think yes and no. I think they're trying. You know, they have a huge responsibility to put out information as best they know it and interpret it. And I think they got a lot of people together. They created committees to try to come to a common understanding of what's the best thing to do in a situation where, truthfully, nobody knows what the best thing to do is. I think we, on an individual level at IHR, tried to do exactly the same thing. We used some common sense. We looked at history, what happens to people in previous coronavirus infections. Yes, this is a different one, but we can at least think of the biology of the infectivity, et cetera, of this type of bug in a situation. We looked at the risks and benefits. We looked about how to mitigate those risks as much as humanly possible. And ultimately, we rely on the patient to make a decision about their own comfort in the same way that we do for pretty much everything else. It's our job to give them any information that exists, but we can't, we're not paternalistic enough to say you can't do this or you can do this, that these are the rules, because that implies that there's some well of knowledge where somebody knows what the exact right answer is. Mm-hmm. I never tell somebody that you won't miscarry. Of course not, because I don't know. Despite our best efforts, I never tell somebody that there's no risk of birth defects, because there is a baseline risk of birth defects. It just is. And I never tell somebody that based on whatever their other medical concerns are, whether it be coronavirus or something else, that there may not be an enhanced risk above their baseline risk, because there might be. And ultimately the couple or the individual or whomever is my patient has to decide with me holding their hand.
Very good. Dr. Huddleston, I'm gonna ask you the same question in case if you didn't hear it. We were talking about ASHRA, ASRM, CDC. Have you received enough information that will help you or guide you through your, consultation with the patients or other organizations?
Yeah, I mean, I think it's such a not it's such a new situation for all of us to be dealing with something in medicine that is just actually evolving in front of us. And so, unlike many other issues that we need to learn about, where I think those organizations have been able to provide really up-to-date information, this has been changing in real time and new information coming out that I think both those organizations have been helpful, but I think probably most physicians are also just going to as many sources as they can and looking at what's being published, because it's changing every day. I mean, ASRM might put out a guideline, but in 2 weeks there could be data that's being released. So I think all of us are, kind of for the first time since medical school, really learning a lot about something new and trying to just understand it the best we can so that we can then communicate that to our patients. And I think Dr. Cohen's right. I mean, there's a certain amount of uncertainty. And so our job is to communicate everything we do know and to help the patients feel informed to make the decision that is best for them.
Fantastic. Dr. Koo?
Totally agree. I mean, these guys said it perfectly. I think that all those groups are doing their best, like they were saying, and providing as much information. And I agree, as clinicians, try to do the best thing, keep our patients' interests at heart, and just to give them all the data so that we as a team together can make a good decision as to whether we can proceed forward or not.
Fantastic. Don? I know
Well,
you're not.
Yeah, I'm not a, but because we are an education-based organization, and we try to be the bridge between the research community and the patient community, we do go to those sources all the time. And I just second with everybody. I actually think they've done a very good job. And I really thought I think it was a hard decision the ASRM had to make to recommend stopping treatments. And I was really impressed that they made the hard decision. And I think that shows that their heart is truly in the right place of wanting to do right by patients in an unknown situation. And it occurs to me that I was smiling at when Dr. Huddleston was saying that this is the first time since medical school. It has occurred to me so many times when talking with patients that we are all spoiled to thinking that we have information, literally at our fingertips, in our pocket, in our purses, constantly. If there is a question in my house that, somebody will say, Google it, so it's like we're not used as consumers of medicine, but as practitioners as well, probably, we're not used to the unknown. We're not used to not knowing. And in the past, I think people probably maybe it was easier to live in the unknown because it was a more common thing. It's pretty uncommon for us. So I think that's something that's universal to all of us, both patients, patient educators and doctors, is that this living in the unknown is sometimes not comfortable.
Yeah, true, very true. Before we go into the next question, the next question will be about risk assessments for COVID-19. But before we go into that, we're going to get some questions from patients. We have about 60 patients in this webinar. Miriam, can you please bring those questions, and we're going to ask each physician one question. Don will have also a question for you. Miriam?
Certainly. A very popular question that we've received is from Kim, and she was asking, if the vaccine were to come out, would you advise your pregnant patients to vaccinate?
Should we start with you, Dr. Huddleston? I know you're not in the vaccine,
Yeah, I mean, I would defer also to anyone who has insights into this, but I think it will probably depend on the vaccine and just knowing the details of the vaccine and how it's made, and whether it could pose any risk to women who are actively pregnant, I suppose. But in general, I think the goal is to have a vaccine that is going to be usable by women who are planning to get pregnant or are pregnant. I mean, in the same way that the flu vaccine and things like this are always highly encouraged for pregnant women or women planning pregnancy. But until we know exactly what it is, I don't know that we can say.
Very good.
Yeah, how it's made. Is it an attenuated virus or is it live?
Right.
These are the nuances. We're not virologists. We'd have to rely on people. And you'd go back in history and study what happened in the past. You know, polio was good for millions of people, but there was definitely a group that was hurt by the virus, by vaccination. So it would depend exactly on the type of vaccination it was.
Exactly right. It all depends on the type of vaccination. I think the vaccination will kind of determine whether we can offer it safely to the patients who are pregnant or not. Yeah, it's interesting. I know that there are a lot of multiple sources that are working on different types of vaccinations for COVID. So I'm really hopeful for the future that we'll have a vaccine in our hands very shortly here, I hope.
Very good.
And we might even have, more than one that ultimately is successful. I mean, and that is hopefully, I'm not being too optimistic there, but if that's the case, then it may be that there's certain vaccines that are appropriate for women in childbearing age and maybe some that aren't. And so we'll be able to use the one that's safest.
Okay. Miriam, can you take the second question?
Yes, this was also another popular question, but Teresa asked, what would happen if we began treatment and things were to shut down again, possibly due to a second wave or things like that?
Okay. I think we're going to get one question per physician because we have a bunch of questions. So, anyone can take the question and we're going to go to the next one. And I'll start with the same order.
Oh, okay. Do you want me to go or?
Sure.
So, I mean, I think that, obviously that's on everyone's mind that there could be another second wave. And I think it's, hopefully there isn't going to be, but at least I think for our clinic, it really is going to come down to what's the guidance coming from national organizations and also what's the guidance coming from the local governments. We know that this is the way that this pandemic has unfolded. Certain waves are going to be bigger in certain places. And so if the concern is that San Francisco or the Bay Area is going to have a wave that could threaten hospital capacity in a way that would be bad for public health, then then we would close down. I mean, because that's ultimately has to be the priority. So we would have to listen to our local authorities. And then, very similar to what happened in March and April, I mean, I think we ended up finishing out cycles that had already started because it's for a lot of reasons not ideal for women to stop mid-treatment, but we paused new cycles until it was safe again to restart.
Very good. Thank you so much. Miriam, one more?
Yes. Another question that we received is, are you recommending for patients that are seeking IVF treatment to visit their family and friends now that restrictions have started loosening across the country?
Actually, no. We would prefer that people maintain the social distancing as much as humanly possible. Obviously, if they have to see family and friends for other reasons, then yes. But as a general rule, no, I prefer that they don't get infected, not only for them, but for what they're going to bring to our surgery center, what they're going to bring to my office, and the health and safety of my staff and my partner and my my other patients. So I would prefer that people wear masks, social distance, follow the general guidelines, and only go to new places, especially with family and friends, if they absolutely have to. So I would have them think twice. I think it best would be my advice.
Very good. Let's go to the next question.
Next question is from Christina, and she was just asking, given the pandemic, does the stimulation protocol matter?
You know, at our facility, despite the pandemic going on and COVID-19 infections and all the spikes, we haven't changed our protocols. Our protocols are still the same. We treat each patient individually, and we'll tailor a protocol to them. But whether there's a pandemic or not, at this point in time for our facility, we haven't changed our protocols. So we are still a go 100% for the same treatments.
We have one question on embryo transfer from Tam. Can you give us that question, Miriam?
Yes, so Tam asks, is it good time for an embryo transfer right now while we're in the middle of a coronavirus? And then what problems do you think we will run to when the winter time comes and a second wave of the virus takes place? I know the second part was already answered, but what are your recommendations as far as embryo transfer goes?
You know, at this point, there isn't a recommendation to not proceed with embryo transfers in the same way that there is not a recommendation for women in general to not get pregnant. So I think we would consider fertility patients the same way we would consider any woman who would desire building a family at this time. And so what we do know is that there's uncertainty around what this virus could mean if an infection took place in pregnancy, and we can pull information from a variety of places to try to guess at whether we think there's risk or not, but at the end of the day, there's some uncertainty. And so that, just as I think Dr. Cohen was talking about, it's really about reviewing what we do know with patients and helping them make the decision around whether this is an appropriate time. I think the tricky thing is this isn't probably going to be over in a few months, as we know. And so when you're talking about delaying having a family, it's potentially a pretty long timeline. And that's why I certainly in my practice have really not encountered patients who want to wait until this pandemic is over. But they're considering, you know, how they can make themselves as safe as possible during their pregnancy.
Can we take the same opinion from you, Dr. Cohen and Dr. Koo, about transfer, since you guys are working with embryo transfer on a daily basis?
So we stopped frozen embryo transfers. We stopped patients who were getting IUIs, inseminations. But when we started up again, we started up very quickly with frozen embryo transfers, inseminations. And I would echo 100% of what Dr. Huddleston said in terms of the lack of a recommendation to tell women not to have intercourse and to get pregnant naturally. Nobody ever said that, at least not to my knowledge. I think ultimately it boils down to trusting people. Like, they're not stupid. They understand that if you're walking on the street, you know you're living in a pandemic. You have to know by now that it's not going away anytime soon. And yes, you have to decrease your risks. Nobody should be flying to a place where they have Zika virus. In the same way, you shouldn't run to a swimming pool with thousands of people that potentially could be infected with coronavirus. And I'm not trying to be alarmist. I mean, it's not the same disease, clearly. One is dramatically teratogenic like Zika, and one we don't know, and most likely isn't. But I do think a little bit of common sense and trusting our patients to make those decisions is the answer.
We're still doing FETs. We're proceeding forward. I agree. There is no recommendation against proceeding forward in getting pregnant. So these guys said it right. But I agree. Yeah, common sense is important, and working together with the patient as a team to provide the information so that you can decide whether it's the right thing for the patient or not.
Very good. I think we can move to the question, and then we can come back to the patient questions later on, Miriam. I wanted to start a discussion on a STAR study conducted by the University of California, San Francisco. Dr. Huddleston is an investigator in that project. Can you tell us what you guys are doing at UCSF regarding this?
Yeah, so yes, it's called the Aspire study. And we, you know, as the pandemic was kind of getting going, and we were sort of watching in real time as we realized this was going to be something that was around for a while and something that we didn't have a lot of information on. We wanted to launch a study that would be able to help us understand if there are any risks for pregnant women. And our focus with this particular study was to really be able to look at the first trimester, capture women very early in pregnancy, and see if an exposure to the virus happens during pregnancy, but particularly during the first trimester, if there were any difference in outcomes in terms of either maternal health or the outcomes for the babies. So we also realized that within fertility clinics in particular, we actually had kind of a really amazing resource because fertility clinics all across the country, number one, are part of a network called the SART network, the Society of Assisted Reproductive Technology. And all of our clinics take care of women from a very, very early stage of pregnancy. And so we have a lot of information about women in terms of when exactly that got pregnant, and they're sort of in close contact with us in that early stage. So the way our study works is to recruit women all across the country, but partly through these clinics that are infertility clinics. It's not restricted to fertility patients, but we're definitely using the clinics to recruit a fair number of our patients. And the goal of the study is to capture women very early and then follow them through the course of pregnancy using antibody tests weekly, so that we can determine if a woman during the course of her pregnancy did become exposed to the virus and had an infection, whether it was asymptomatic or symptomatic, and to be able to pinpoint when it occurred. And then to be able to go back and look at that group of women who were exposed, which will probably be very small, but there probably will be some people in that group. Look at that group of exposed women compared to all the women who were not exposed, and be able to come up with information that tells us whether or not there is actually any risk to women from this virus. We know that there are viruses that cause big problems, and we know there's a lot of viruses that don't. And so we want to answer that question.
Very good. So the question is, patients that are undergoing IVF fertility treatment, and that's for you, Dr. Cohen and Dr. Koo, are they undergoing any additional risk or exposure compared to general population that are going under pregnancy? Give us your thoughts about that.
Well, yeah, do you want to take that, Dr. Cohen?
Sure. I think the question is, does a patient who conceives through the IVF process versus just naturally at home face a higher risk? Yeah. We don't know the answer to that question. Fundamentally, we don't know the answer to it. I mean, if in a general sense, people are having to come to a clinic, they're meeting with lots of other people, they're going to a surgery center perhaps. Yeah, that might increase slightly because you're amongst other people who are then exponentially exposed to others. The process itself does not seem to lend itself. You have to have biologic plausibility to things in order to make a profound argument one way or the other. And to date, at least from what I've read, I haven't seen the biologic plausibility that giving somebody FSH or LH or Ovidril, which is HCG, or progesterone, or driving somebody's estrogen up higher has a plausible explanation that would make them more sensitive to coronavirus infection. It's just not there. I don't see it in other viruses either. That doesn't mean it isn't. It just means that if it is, it's going to be a very small delta, a very small number above the baseline that might be vulnerable. But so far, no. I would say no.
Okay.
Overall.
Very good.
Yeah, I agree.
Answer. I apologize.
No, I agree. It's perfect. I think that women who conceive through assisted reproductive technologies versus conceiving on their own, I think that they're at no greater risk with IVF or IUI as compared to conceiving on their own. Putting aside all the things like Dr. Cohen was saying, like if they meet other people or they're surrounded by other people at the office. But I think when all things are equal, I think it's, so far as we know, it should be okay.
Yeah. Don, this is one of the questions you have gotten most, you mentioned earlier from patients that you have spoken to, correct? They're trying to figure out if there is any additional risk.
Yes, that question, and also just is there, especially in cases where it's a frozen embryo transfer. So they're, you know, they could technically, their age, waiting 2 months wouldn't necessarily impact their fertility because the embryo is already frozen. So I hear less whether the question about whether they're at increased risk because of going through fertility treatment. What we hear more is, one, am I at increased risk by being pregnant? Or two, am I exposing my baby to increased risk by trying to get pregnant during a pandemic? That's what we hear more. It could be that we just haven't heard the other question, though.
Very good. Claire, what is your take on this? Did you have any concern?
Yeah, I have a little bit concerned. Like, obviously, I'm just at an increased risk of exposure, coming to the office, being in contact with people. But again, going back to one of the earlier questions, you know, they're taking the precautions that they can take. So that gives me a little bit more reassurance that hopefully my exposure is more limited than just going into an office with just as many people as before that aren't wearing masks. But yeah, does that answer it?
Last week, we asked one patient that was in the webinar about the same question, and she said that she's more concerned about general population than actual medical facility, just because of that PPE that is being in the medical. It's not the same going to a grocery store than going to a clinic. Clinic is more regulated environments, and that's what she was saying last week. We have just launched the poll for patients, and we're gonna wait for maybe a minute to get the results. I wanted to follow up on the same question I asked earlier. Can you guys give us an idea, what is your risk assessment for COVID-19? What procedures you have in place, and what's your assessments to that risk? And I'll start with the same order.
The risk of people being exposed in the clinic setting, is that the question?
Exposure before, after, during the treatments, how do you assess that risk at your facility? What mechanism you have in place to control for that?
Oh, okay. Yeah, I mean, I think all of us have all instituted a variety of mechanisms to reduce risk. And so there's, you know, screening before people come in the door. So there is, you know, one person in an elevator at a time. Everyone is 6 feet apart, you know, in the clinic at any time. You know, everyone has masks. There's a lot of, you know, enhanced cleaning strategies. And then we are testing our patients who are going to be having anesthesia. And because all of our IVF patients have anesthesia, we actually end up testing them before they even start the cycle as well, just because we don't want them to start the cycle and then find out they've been brewing something, or we want to minimize how much that happens. And so there's also that. You know, ultimately, I think a big factor in all this is going to be just the rate of, or the sort of the prevalence of of COVID-19 in the population of the clinic, you know, of what city the clinic is in. And so I think that's an important thing for patients to think about. If they're worried about risk of their clinic, they can know that clinics are doing everything in their capacity. But what's going to be a big variable in that, and whether there's any additional risk, I think is going to be what's going on in the population where that clinic is.
Very good. Dr. Cohen?
I completely agree. It starts before they come. They're well aware that they're going to have their temperature taken, that everybody's wearing a mask, that every single surface is washed down with some alcohol-based solution every 15 minutes or so. That we don't shake hands, we don't do things, you know, physical contact. I think we're doing all of those things. We are also telling people to sign, for example, a piece of paper that says, if you understand that if you turn positive, even though you're on day 5 of stimulation, we're going to cancel you. We're not going to think about it. We're going to cancel you. I actually had a patient who couldn't get started with a cancer patient, actually, who we were going to freeze eggs. So on top of everything else, we had that as a concern, and we canceled her. And she was very fine with it, actually. She was a little bit concerned about whether or not she was going to freeze her eggs anyway. And in the end of the day, it worked out okay. But the point is, we are sticking to that protocol as well.
Very good. Dr. Ku?
Yeah, like my colleagues, we're doing everything as well. Patients need to call before they can enter into the office. One of my nurses will meet them at the door, take their temperature. They must fill out a survey saying that they attest that they have not traveled anywhere that has been an area that is a high spike of coronavirus. They haven't had a fever in the last 24 hours. Additionally, they also have to wear their masks, and our employees have to wear masks. And actually, every employee and every physician has to get their temperature taken, and they have to also sign a survey that says that they have not been exposed either. So every morning I get my temperature taken, and I have to sign that, yep, I'm good. So we're taking every precaution. We're wiping down the surfaces every minute. Not every minute, sorry. After every patient is in the room, we clean out the room, but every hard surface is cleaned in our facility every 30 minutes to an hour. We have someone wiping. It's quite rigorous. I think that our clinic has never been cleaner, to be honest, with the amount of cleaning that we've been doing. So we are taking every precaution, and we're taking it seriously. We want to make sure that we keep not only our patients safe, but also our staff and our physicians safe too.
Fantastic. Don, do you want to add something?
No, I think that's probably better left to the doctors.
Very good. Let's go to the poll, and we'll get the data. Miriam, if you can give us the results.
Yeah, so we asked a total of 3 questions. The first one being, are you currently seeking fertility treatment, or will you be in the future? 70% of our participants said yes, and 30% said no. 2, are you concerned about contracting COVID during treatment? 39% were very concerned, 45% were somewhat concerned, and 15% were not concerned. And then the last question was, are you following general guidance on social distancing while taking extra precautions? 88% of participants said yes, 9% said somewhat, and then 3% said no.
Very good. Thank you so much. Any feedback on the poll? Dr. Huddleston?
No, I mean, I think it's what I probably would have expected.
Yeah.
It says exactly what I thought our patients that are smart, observant, protective of themselves and their families would say.
I agree. I'm very pleased to see that 88%, almost 90% are taking the precautions seriously. Whereas when I go walking outside, I'm like, where are the masks? No one's wearing their masks. So I'm happy to see that the patients are taking it seriously. So thank you, guys.
Very good. Don, any comments?
The same thing. I was going to say exactly that. I'm just very thankful to see people. That actually is very reflective of what I'm hearing as well. They are more cautious because they have reason to be more cautious.
Very good. Are you guys using any testing? Are you screening? How are you guys screening patients besides temperature? Are you doing any testing?
We are doing the COVID-19 RNA test prior to initiating the cycle, and then doing it within a couple of days of the egg retrieval. And then anyone who's having surgery that requires anesthesia is also getting tested. But that's really it. I mean, we're not broadly testing everyone that's coming in for intrauterine inseminations or other things. It's in some ways focused around the group of patients that are proceeding down a road that's going to require anesthesia.
Very good.
Yeah, we're similar. We did not, anybody who's going for a procedure like a hysteroscopy, for example, getting anesthesia, has to be tested. Initially had to be negative within 72 hours, and it was switched to 96 hours. And if it wasn't, we haven't had it positive yet, I don't think, but if it isn't negative, they're canceled. For IVF, initially we did not. We're instituting that now, before people get started, that we're going to have them get tested along the same lines, and we'll probably do it for IUI as well. We do not do it though for things like, you know, HSN or SIS, whatever you guys call it, ultrasounds in the office, where fluid infusion or physical exams in the office. Not yet anyway. There is an issue of obtaining all of these tests and paying for all of these tests, and it's not so easy to just say, oh, let's just get all these tests, and then you have to manage the results of them, and you know, it makes me think back to the days of, you know, AIDS testing, when you couldn't just order an HIV test like we do now. You had to think it through, and how are you going to explain it to patients, and how are you going to manage this information? And so I think we've all been faced with that difficulty. But ultimately, we're heading towards testing more.
Yeah, we're testing a lot as well. I agree with Dr. Cohen. It has been a little bit tougher for us here in Dallas to find a place that would do the testing, and luckily we found some places, and we've utilized them more extensively. But we struggled to decide whether should we do nasal swabs or should we do antibody testing, and what does it mean, and when do the antibodies arrive? And like we were saying before, this is a brand new thing. Is it 14 days after you're asymptomatic and you get the antibody? We don't know when these antibodies arrive, so we really struggled to decide which one to do. And even if we did want to do the nasal swab, we didn't have the capabilities to do it in our facility, and who do we send it to? So we try to find a place where they could drive through and get it done before their retrieval, for example. And it was so hard to find a place that would do it. A lot of places said, look, they have to be symptomatic before they'll do the nasal swabs. And oh my goodness, you know, what about the asymptomatic folks? So in the end, we are checking the RNA at stem start. We also check it at trigger shot before retrieval. And we're checking it for FET patients before they begin their stems or their medicines as well. And I agree with Dr. Huddleston, any patient that's headed towards any sort of anesthesia type of procedure or requiring procedure. So we will do the testing for that. But we were not testing the ultrasound patients or the IUI patients at this time.
Very good. Very good. Miriam, we're going to get maybe 3 more questions from patients, and then we get into the next phase, which is maybe wrapping up the webinar. Would you be able to read those questions that are more technical? I know that we have few from anonymous patients, right?
Yes. So we have a few questions that are not necessarily COVID related. We have one anonymous patient asking, what are the benefits of weight loss and fertility? And what are your thoughts on a keto diet and whether it could be good for fertility?
We can start with anyone who is willing to answer the question. We have 2 more questions.
Go ahead, Dr. Cohen, please.
I was going to say on the weight loss issue, I do tell patients that if their BMI is high, that they need to consider weight loss before they conceive, and that excessive weight has been shown to lead to increased risks with their pregnancy and has lowered fertility rates. So I do counsel them about that. We do have patients who, if their BMI is above 40, we may not be able to do the retrieval because anesthesia is worried about their safety during anesthesia and that they're worried about their throat closing up. So I do talk to them about weight loss. We refer them to a nutritionist, and actually I kind of talked to the patient and said, okay, look, I need to lose 10 pounds. Let's do this. Let's have a contract. When I see you again in the next couple of weeks, how about I've lost 5 pounds and you lost 5 pounds, and let's do this. So we're a team, and so that's what I tell patients about weight loss.
Very good. Thank you. Miriam?
Next question is from Julia, and she just asks, so she's currently 48 years old, but froze her eggs at the age of 43. She actually lives in Chicago. She's now ready to have a baby and is asking, what factors should she consider in deciding or choosing a fertility center?
That's a good question.
Well, I'm in Chicago, so I'm happy to take that one. So she's 48 now. Is that what you said?
Yeah, she's 48 now, but she had her eggs frozen at the age of 43.
So at 43, eggs that are fertilized and make it to be blastocysts, which is the stage of development that an embryo is when it enters into the uterus normally. Those blastocysts still have almost an 80%, maybe higher chance of being genetically abnormal. So I first and foremost recommend that if she's going to do this, she should test those embryos. As far as her general health is concerned, she should be seen by a primary care doc to make sure that she's otherwise in generally good health for her obstetrically to carry a pregnancy. Most 48-year-old women are, so chances are she's fine. But you know, somebody should review any medication she's on. Somebody should check her weight and blood pressure, etc. This is sort of obvious stuff. In picking a clinic, I think she just has to find a physician that she relates to, pick a place that has a good reputation, sort of seems obvious to me, and then move forward.
Very good. We initially, when we had this started this webinar, Claire, you had a question, right? A question I forgot to ask you. Could you tell us what is your question and see if the panel can address that?
I just had a question about if there's data out there nationally on if pregnancy rates in general are increasing, decreasing, or staying normal during this time.
Who wants that?
Yep.
I'm happy to start that one, but people can chime in. I don't know that there's a great answer to that, but I don't know that we know. I haven't seen that data be described yet. I think it will be interesting to see what happens with fertility rates during this time. There's so many factors in play that you could see it going in a number of directions, actually. But I don't think we know right now.
Very good.
Yeah, I agree. I don't think we know right now. I think globally, in the United States, before all of this, the numbers were going down, right? So the fertility rate was clearly decreasing. In a very short period of time, in these few months, there's plenty of data from previous lock-ins, you know, times when there were blackouts, and just do the math, and 9 months later, you find there's a lot of babies. I don't think you have to be much of a genius to figure out what's going on there. If people are locked up at home. So is that really a fertility rate, or is that just a spike, an opportune spike, more likely? A sporadic spike is more likely the explanation. As far as what the coronavirus specific, you know, effect could have on that, it's way too early to make that observation, way too early.
Hopefully we'll get that data soon. Yeah, I agree the jury's still out on that one.
Yeah, I mean, I think the other thing that I'll be interested to see is just because the economy is, you know, going to be challenged, what that's going to mean for people. I know when in 2009, when there was sort of the recession then, that there was not only with IVF pregnancies, but just generally there was a dip, because when there's uncertainty around your job and your financial future, I do think that can sometimes impact people's family building desire. So certainly hoping that what goes on with our economy is going to also, you know, be short-lived, so that that's not a big factor for people.
I have a question, a follow-up question. When do you expect to have some data on pregnancy and COVID-19? So I think most people are looking for that kind of data to be able to counsel their patients and understand better, you know, if there is any potential risk or mitigation that needs to be done. When do you think you would have some sort of data to share?
I mean, I think it's going to potentially be a while before we have, certainly with the study we're doing that's looking at the first trimester, it's going to be a while before we really know if there's adverse risks for the outcome of the pregnancy, that especially in terms of newborn outcomes. We're already seeing some reports though from pregnancies that have been impacted by COVID, especially later in pregnancy. And I would say overall, the data is pretty reassuring. There hasn't been marked problems seen with either women getting much more sick or with babies being sick. So I think so far it looks okay. But there have been some reports suggesting that there's more inflammation or impact to the placenta. So I just think that we have a lot to learn. I think at this point, it just makes sense to be as careful as you can if you're pregnant. And, I don't think that recommendation is going to change for a while. So it will be a while before we have that good data.
And we have gone through that study last webinar, the study showing the inflammation or lesion on the placenta. I think there were 16 patients, 15 of them delivered healthy babies there was no evidence of impacts on newborn. I think that's what we have discussed last week. We are getting close to the end of the webinar. I would like to give you guys a little bit of time to introduce your organization and tell us what you do, so that patients that are listening to this webinar will learn a little bit more about you. And I will start with the same order.
Okay, my dogs just came in the room, so you might hear growling.
Yeah.
Oh my gosh, sorry. Okay, so anyway, I'm from University of California, San Francisco, and I'm a reproductive endocrinologist, and I take care of patients, and then we also have research interests at our center, and so I'm one of the co-investigators in the ASPIRE study that we are looking for patients to participate in. The study, if you are pregnant between 4 and 10 weeks, is actually the enrollment criteria.
Very good. Dr. Cohen?
So I'm at the Institute for Human Reproduction. I've been there since 2014. Before that, I was at the University of Chicago for almost 20 years. My personal interest is really and has been for many, many years in fertility preservation. And of course, in helping people try to get pregnant with in vitro fertilization, et cetera. We have a very strong interest. My partner is a world leader in the genetics of reproduction and in testing of embryos for all sorts of diseases, whether it's single gene defects or X-linked diseases or just aneuploidy or both. So that would be the areas of interest of our practice primarily.
Very good. Dr. Koo?
Yes, I'm Lowell Koo, and I'm the medical director of Dallas IVF. We are a private practice in Dallas. We do about 1,000 cycles a year, so we're sort of a medium type of practice. But my specialty has always been PCOS and AMH. Actually, it was my thesis that I had to defend during the oral boards. So I've been with the practice since 2008, and if you're in the Dallas area, need a little help, come and see us.
Don?
I am with Creating a Family. We are the National Infertility Education and Support nonprofit. We provide lots and lots of resources. As I mentioned before, we try to be the bridge between the research community and the patient community. We touch on every aspect of infertility, a lot on the emotional aspects as well. And as I mentioned, we have a weekly podcast, and you can subscribe, Creating a Family, on any of your whatever podcast app you like, and you will get every other week information that is relevant to any aspect of infertility you could be thinking about.
Fantastic. Claire, any last comments?
Oh, good luck to everyone out there. I wish the best for everyone.
And
To you.
And we thank
to you too.
Yeah.
As well. We thank you so much for bringing the patient perspective and being here talking about treatments. I'm going to go through the last poll that we have released. Miriam, can you take us through that exercise?
I'm actually not able to view it.
Okay, I'm gonna read that for you guys. Basically, we asked the audience if the webinar has addressed some of the concerns that they had. 59% said yes, 38% said somewhat yes, and 3% said no. We asked them, would you like to see more webinars like this on COVID-19 and pregnancy? 90% said yes, and 10% said no. The good result is really because of your amount of information and really your knowledge and expertise. We thank all our panel for bringing the expertise to this webinar. Thank you so much. With this poll results, we come to the end of the webinar. Thank you so much. Next week, we will have another webinar more geared towards embryologists. And we're gonna be learning about each clinic and what they're doing differently during COVID-19. Thank you so much for attending the webinar, and I will see you soon. Thank you.
Thank you, guys. Thank you.
Thank you.
It's a pleasure, everybody.
Bye, guys. Thank you.
Bye-bye.
Thank you, everyone.